I'm Amy. I don't work anywhere. I'm a student. So
What school?
Central Washington.
Hi, my name is Laura Perez, and I've missed a couple meetings before, but trying to get involved into the medical assistant so that I can do my testing and become certified.
Carol Yons, retired medical assistant for a new member of the organization.
I'm Melissa Perrin. Right now I work at neurology and rheumatology, and I teach sometimes at Whatcom.
I'm Jeff Thomas, and I'm one of Pam's students over at Whatcom Community College for the medical assistance program.
Thank you. Well, welcome everyone. There's two sign-up-ships going on. One is, it says a non-member, which is a non-member of the double AMA. So if you're a student or don't have a membership with a double AMA, you sign on that one. And the other one is a member, so whoever has a membership with a double AMA. So I'll let Pam do her presentation.
So I'm Pam Meyer. I teach at Whatcom Community College, and I'm a CMA, double AMA, and I'm a respiratory therapist. And so this goes back to my first love of respiratory therapy, and kind of intimidating having somebody who works in it, because you could correct some of my stuff and I would accept that. Okay, so first off, since I work at the college, I have to make some announcements. So the college is offering an introduction to behavior health, and it counts for 30 CEUs, the non-AAMA CEUs, if you take this class in the winter. And I have just one of each, but if you are interested in taking that, you can take a look at these. I can pass them around too. And we're also offering a medical interpretation class so you can put your bilingual skills to use and learn how to do medical interpreting. So pass those around, and if you're interested, you have to go to the website and sign up, or there's some phone numbers on there or something too. I'm not in charge of those. I'm just making the announcement.
Messenger.
What?
The messenger.
I'm the messenger, yes. So I handed out straws. Did everybody get one? You want one, Anthony? So with asthma, your airways are, let me get down here. I thought that was a cool one, so I had to put that one up. So I have to tell you, I just taught a computers class, and so I had the students do all these fun transitions and animations, and so I have to do them now in my PowerPoint because I figured if the students were here I'd be in trouble if I didn't. So the objectives tonight are to define asthma, diagnose asthma, what causes it, common treatments, and the effects of non-treatment. So I was starting to say, asthma is the narrowing of the airways. Some of it, oh, that's not very clear in here, but you can see here it's like pretty wide open, and on the asthmatic one, it's a pretty small opening. So it's a combination of bronchial constriction and mucus, or swelling. Actually, more the swelling of the tissues because of the irritation. And some mucus plugs too. But so if you breathe through your straw, and not through your nose, just through your straw, do like 10 breaths and feel what it's like to try to fight for that air. After a while it gets really hard and you're kind of fighting for it. So because we have big airways, not little ones. So that's a little bit of an idea of what it feels like to breathe through that narrowed airway. So what is asthma? It's chronic. There's no cure for it, but there's treatment for it. It's inflammation of the bronchioles, and what are bronchioles? So your lungs are like a tree. They have a trunk, which you call the trachea, actually like an upside down tree. So there's the trunk, the trachea, and then there are bronchioles that come off of, the bronchi come off of it, and then so you have two lungs, and then one breaks down into 3 lobes and one into 2. Boy, it's been a long time and I'm on the spot. Anyway, so they break down and then they get really small, and the really small ones are the bronchioles. So it gets smaller and smaller, just like your veins get smaller and smaller, and they actually get bigger and bigger. Arteries get smaller and smaller as they go to your fingertips. The lung acts the same way with their trees. So there's inflammation, which narrows it because of the swelling inside of it. There's bronchial constriction, which is a smooth muscle contraction of the bronchioles, which makes them squeeze up and harder to breathe through. It's usually hypersensitive airways. So some people can, we'll use perfume as an example. Some people can handle smells and perfumes and it's just fine. Some people are hypersensitive to it and they breathe it in and their airways start to react. There are 2 basic types. There's the allergic, which is the most common one in children and is caused by allergens, which we'll go over in a little bit. And there's the, and I had it, I can't say it now,
Eosinophilic.
Eosinophilic, okay. I looked it up, I really did. And then when I stand here, I can't come up with it, of course, because I'm standing here, right? Which that is more common onset with adults. See that transition? So, how is it diagnosed? Spirometry, and I wanted to pass, I didn't make enough copies for everybody, so if you can kind of share some of them. This is a normal spirometry, and this was actually mine that I did yesterday. So that's what normal looks like. Peak flow. So the term peak flow, actually I think I get into it further later, but the peak flow means the fastest point of exhalation, the fastest you can get it to go. So when you blow on these, this little indicator goes to where it was the fastest and it stays there. And so you can see how fast the exhale was. Methacholine, there's a methacholine challenge, and I get into that a little bit later. There's pheno testing, which is fractional exhaled nitrous oxide. And before we get, so that's the ways to diagnose it, but I want you to listen to, because breath sounds are an important part of it, and I'm going to have you listen to some breath sounds. So this is, no, that's not where I want to be. That doesn't sound too nice coming through here, but that represents a normal breath sound. And this is what wheezing sounds like. You hear the squeaky in there? Yeah. And this is bronchi, which is not wheezing. So it's abnormal, but it's not wheezing. I'll stop that. This is when there's a lot of bronchioles constricted, a lot more noise.
You didn't stop it yet. That works, I guess.
Stop. No. That will stop it. And here's another wheezing. How many of you do listen to breath sounds on the job? Yeah, of course. So, back when I worked in the hospital, all the respiratory therapists and the pulmonologist, and maybe Sandy can tell me if it's true today, which stethoscope do you think is my respiratory therapy one? Any other guesses?
The shorter one.
The shorter one. And do you know why that is?
That was pediatric.
Well, this one has both. Mine, this one is mine. I lost my pediatric one. Shorter, there's less artifact in it, so you can hear breath sounds clear. Now, I would probably never do blood pressure with this shorter one, because you gotta be right in their faces, right? So, I would use a longer one like this for the breath sounds. I mean, for blood pressure. But for breath sounds, all of the respiratory therapists and the pulmonologists had really short ones, and which were kind of a pain because they didn't really work around the neck like the others do, right?
They carry them in their pocket.
They carry them in their pocket, yeah. Because it was really handy before we all cut ours off, because we would all walk around the hospital like this, you know. We always had our stethoscopes on, and so they weren't in the way, they didn't bother us, but those short ones became a problem. But we could get better breath sounds. So as a respiratory therapist, when we would do nebulizer treatments with bronchodilators, we'd listen to the breath sounds before and after, and then chart. That would be A for assessment on how effective the treatment was, if it made a difference to the patient or not. So, spirometry, which I just handed out. Those show you how much air you can inhale, and then how much air you can exhale. That's what that loop is. The bottom is inhale, and the top is exhale. But what we're really measuring in this for asthma is to see how fast you can exhale it. Because when you're constricted like that, it's harder to exhale. And especially on exhalation, the bronchioles, it's like when you inhale, they open, but when you exhale, they get tighter. And so it's harder to exhale. And so for patients, we'll use spirometry for diagnosis, and then also to check to see how effective a treatment was. Now, we always use breath sounds when I was working, but you wouldn't do a spirometry for every test or every treatment. But you would do it as a spirometry in the doctor's office to see if that medication you just nebulized or the inhaler, how effective it was. So on the back page of that handout, I have definitions. And so you can see here that this is inspiration. It starts here, goes up, and then down like that. And so it tells what all these are, what all those terms mean. Which I have FEV1, forced expiratory volume in the first second. FVC is forced vital capacity. And FVC1 over FVC is the, so there's a percentage that should be, you should get so much of it. Okay, percentages of expected are done by age, gender, height, weight. And it's all in the computer, and I can't tell you numbers off the top of my head because there's just way too many numbers and factors in that. So, so for, you can see on mine, I'm at normal for my age, height, weight, and gender.
And nationality.
And nationality. I
It
forgot
asks
that.
for smokers too, it was. Well, on PFTs,
Okay, so our machine at the school did not ask about smoking,
no.
but it did race. Because these are what should be normal for people, but PFTs, they do want to know.
You
So-
enter all of it into a machine and it gives you a predicted value.
Right,
And then you're comparing it against the predicted value.
right. So I fit within the predicted value, which made me feel good yesterday because
You're normal. On paper, you're normal.
On paper, I'm normal. Imagine that. Shocking, isn't it? So, so mild asthma is less than, FVT1 says greater than 80%. Boy, my numbers got off there. Okay, but moderate, you're going to be between 60 and 80. So mild, it's not going to make a really big difference on your breathing. You're not. So normal is between 80 and 120% of predicted. So mild is still probably low range of that. But then moderate is between 60 and 80%, and severe is if you are less than 60% predicted on those numbers. And that means you're really struggling to breathe. Moderate, you're probably struggling to breathe, but severe, you're really having some problems with it. Oh, there's my glossary. So do you know what vital capacity is? Vital capacity is the maximum you can inhale, and the maximum that can be are in your lungs. So that's at the bottom here. The largest amount measured on complete exhalation after full inhalation. So you, and then what you can blow all the way out would be the amount that's your vital capacity. Forced vital capacity is different because it's that same amount, except it's what you force out, and forcing it will decrease the amount you can blow out. So forced vital capacity, especially if you have COPD or asthma or something, it will be, those numbers will drop, and instead of being a pretty fast exhale, you'll go, and it'll slow down and you won't be able to exhale nearly as much as fast. So the one thing they really, really look for is the forced expiratory volume in 1 second, because that shows when you're really trying to force it out, if you really can't get it forced out.
Maximum effort.
Maximum effort, yes, sorry.
That's okay.
Because if they're not doing maximum effort, it's not really going to count. So you have to watch your patient, you have to have eyes on them. One thing, respiratory therapists, we tend to be really machine oriented and don't pay attention to the patient because we're looking at the machines and the numbers and everything, and we have to remember to step back and look at patients all the time because we tend to, like we're working with ventilators, we don't care what the patient looks like, are all our numbers right? And blood work, we look at test results and stuff, and it's like, look at the patient. I was at a respiratory therapy conference one time, and this doctor, he was really good. He was speaking, a pulmonologist speaking on, he says, you got this patient in the emergency room, and you keep doing blood gases. They're really breathing hard, but their blood gases are normal. And they're really working, and their blood gases are normal. And they're really working, and then they fall over dead. They died of poopiness. You didn't even look at the patient. All you did was look at the numbers.
Yeah.
You gotta look at your patient. So that's one of the things too. are they really putting an effort into it? Or are they just, you know, and that's part of your responsibility. We always, you know, okay, take a big, big breath, big, 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 blow, 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 blow. You know, get them, really get in there with them and get it going with them. Now I'm dry. So peak flow. Here are two different peak flow devices. I have one of them pictured here. So these you can use as a quick thing in the clinic, and these the patients take home. And this helps in the clinic. You give them either a neb treatment or an inhaler, and you see if it made a difference on how fast they can blow out their air. And but at home, they should do this twice a day, same time every day, like morning and evening, and monitor their breathing, because sometimes they don't catch the first signs of asthma, and they want to catch it early and stop it from getting to a serious issue. And so kind of nip it in the bud, right? You want to take care of things right away and stay on your medication. But this will show them if they're worsening. So this one doesn't have it, but this one has red, yellow, and green little markers that you can move to where they're expected to be, and then the patient can record where they actually get, and their goal is to be between these two areas. They don't want to be down in the red, they really want to be above the green. So anyway, so they can use a rescue inhaler, or like lots of people, they may have not been taking their steroids or their stuff like they should have, and it reminds them to get back on it. If they do this twice a day, of course, if they're doing this twice a day, they're probably the rule follower that takes their medications right too.
Or if they're not taking them correctly.
Or if they're not taking them correctly. We sometimes think everything's magical and that it should just work the way we want it to, and we don't have to follow the rules. So this is something that you would be training a patient on setting the goals. These are really hard to move, which is intentional, because then they can't move them themselves, or it's not easy, they'll get bumped and stuff. But so you want to set them probably with the advice of the doctor, depending on where you work and stuff. But so encourage them to use those twice a day. And so if it decreases, a decrease in peak flow equals an increase in symptoms.